Good morning, everybody. We're going to get started. Thank you for coming. So my name is Doug Opel. I'm the Director of Clinical Ethics here at Children's. And before I introduce our speaker this morning, I'd like to say a few words about today's Grand Rounds. So today's lecture is the Truman Katz lecture in Pediatric Bioethics, and is a lecture in honor of Truman Katz. Truman was our president and CEO here at Children's for 26 years, from 1979 to 2005. And over the years, Truman has been recognized for his visionary leadership, guiding Children's to financial stability, developing broad-based community support for the hospital and its mission, and for expanding pediatric subspecialty services at Children's and through regional clinics to meet the diverse health needs of children. During his tenure here at Children's, some of Truman's many accomplishments include the development of a strong and effective partnership between the university and Children's that serves as a model program for other academic private partnerships. He worked diligently with the UW and Fred Hutch to develop the SCCA to speed the delivery of new treatments for cancer, and he initiated the strengthening of the research program and prompted a strategic plan to grow research. He did this all the while working with federal and state legislators, physician leaders, and the governor in advocating for child health, injury prevention, and early learning. Now, one of his other accomplishments was his commitment to developing the first Center for Pediatric Bioethics, which emerged out of his long-standing interest in quality of care and respecting the role of families, as well as an emerging appreciation of the role of clinical research in advancing pediatric health care. So in honor of Truman and his incredible achievements, the Board of Trustees here at Children's established the Truman Katz Center for Pediatric Bioethics and this Truman Katz Lectureship in Pediatric Bioethics, which occurs annually. So I want to just take this moment to thank Truman, who I don't think is here today, and the board for all they have done in the past to support the center, as well as continuing support and in the future. So now I'd like to introduce today's speaker, Dr. Jennifer Kett. Dr. Kett is a physician and bioethicist who is board certified in neonatology as well as hospice and palliative medicine. In addition to completing her neonatology and palliative medicine fellowship, she also completed a fellowship in pediatric bioethics here at the Truman Katz Center at Seattle Children's. She is currently practicing as a pediatric palliative care physician at Mary Bridge in Tacoma, and she's co-chair of the ethics committee for Mary Bridge and Tacoma General Hospital. Welcome, Dr. Kett.
Thank you. I am really excited to be here today. I have no financial disclosures to make, but I do want to let you know that I'm the palliative medicine physician for the patient that we're going to talk about, and that his case is presented with his family's permission, and they gave me all the photographs to use. It's actually really important and meaningful to them that his story is told. I also want to take the first 30 seconds of my talk to tell you a little bit about Mary Bridge, where I'm coming from, because when I was training here, I think I was under the impression that Seattle Children's was the only children's hospital in Washington State, and that's actually not true. I'm sorry if I'm shocking anyone. There are two others, and one of them is Mary Bridge. So if you hop on I-5 South, and you go about 45 minutes, 9 hours if it's raining, you arrive at the city of Tacoma, which is actually a really lovely city to work in. This is the Mary Bridge outpatient pediatric clinics, and we have pretty much all the pediatric subspecialty services represented, or they're actively recruiting. And then this is the inpatient hospital, and it's attached to Tacoma General, which is the adult hospital, and they do about 4,000 pediatric admissions each year at the Children's Hospital, and then just under 1,000 at the NICU, which is in Teachee. And it's just a really fabulous place to work. So if any of the trainees in the audience are looking for jobs, give Mary Bridge a consideration. Our story today takes place in the NICU. And this patient first came to our attention during a prenatal consultation. His mother was admitted to the hospital in preterm labor when he was at about 25 5/7 weeks gestation. He was known to have multiple congenital anomalies on ultrasound, and these were mostly craniofacial and neurologic. Earlier in pregnancy, termination had been offered or even recommended to the family, and this was declined. And then during this prenatal consultation, comfort care was offered, and it was also declined. He delivered just a couple of days later at 26 weeks and 1 day. He was 940 grams, and in the delivery room, they saw right away his severe craniofacial anomalies. He got a few minutes of positive pressure ventilation and then was placed on CPAP, but he wasn't doing so well on CPAP. And so comfort care was again offered, and again it was declined by the family. The patient was intubated, he was placed on a ventilator and brought down to the NICU. And this is a picture of him, and I think you can see his craniofacial anomalies here in this picture. So this is one of his eyes here. His other eye is actually all the way over here. He really doesn't have a nose to speak of. He had arrhynia and pretty severe mid-face hypoplasia. And this is one of his nares, which is sort of in the expected location, and this is actually another nair up here on his forehead. What you can't see in this picture is his mouth, which had a very, very high arched palate and a sort of atypical shape to it. And this is his brain MRI, and what the radiologist commented on was this big monoventricle here with dilation. There were some signs of aqueductal stenosis, and overall, the radiologist thought this was consistent with lobar holoprosencephaly. Neurology came, and they felt that this case was consistent with lobar holoprosencephaly. They thought intellectual disability of a severe to profound degree is likely, and that ambulation's unlikely for this patient. Genetics came, and they felt that many features of his case were compatible with frontonasal dysplasia. The more severe end of the spectrum, which this case fits, includes congenital brain anomalies and severe cognitive impairment. And someone summed this up in the NICU chart saying he's been evaluated, and the family have been provided with the realistic assessment that he will be severely delayed with a poor quality of life. During the NICU course, there were many offers to withdraw life support, and all of these offers were declined by the family. They were really consistent in their goal that survival was the most important thing to them. They understood that he would have significant disabilities, and they wanted to take him home. That was really all that mattered. Well, you can see in this picture, he starts to get a little bit bigger, and he actually really did quite well during his NICU course. He pretty quickly grew and came down to what would be considered extubatable ventilator settings for another child. Unfortunately, he was also revealed to have no nasal passage. So those sort of rudimentary nares that you saw in the pictures really had no connection to his airway, no connection to his lungs. And as most of you know, this is a real problem for a baby. Babies are obligate nasal breathers, and babies who don't have any connection from their nostrils to their lungs can have a real hard time. He also was developing worsening hydrocephalus, and his head was starting to get bigger and bigger, and actually starting even to be a little bit hard for him to move or for him to be cared for. The NICU team really thought long and hard about this patient and what the different options might be going forward, and really they could only come up with two. One is to go forward with comfort care, and the other was to do a tracheostomy to provide him a stable airway, to do a G-tube so that he'd be able to be fed, and to do a VP shunt to help address his hydrocephalus. And there really weren't thought to be many middle-of-the-road options. This was presented to the family, and as you might guess, they declined comfort care, and they wanted to go forward with trach and G-tube and a VP shunt. And almost the minute this decision was made, the temperature in the NICU went way up. People really started to become very distressed about this case. It was all people could talk about in the hallways, in the break room. My partner is here, and we couldn't walk 5 steps in the hospital without somebody asking us about this case or telling us what they thought about this case. People commented on what they perceived to be his poor quality of life or the poor quality of life he might have in the future. They said things like, "This is unnatural," or "Nature is trying to take its course." And then a well-meaning nurse who was very connected to the family said to this patient's mother, "Some people here don't think he has a soul." And this was devastating for his mom to hear, that these caregivers who they were entrusting with their child's life were talking about him in this way. As is typical when the temperature in the unit goes way up and people are feeling very distressed, an ethics consult was called. And they came and they gave some recommendations on the basis of the best interest standard. I actually think this is the least interesting element of the case. To me, what's more interesting is this incredible degree of moral distress. This is a unit, like the units many of you might work in, where we take care of babies born at 22 weeks gestation, where babies with grade 4 bilateral hemorrhages get a trach and a G-tube and go home, where babies with trisomy 13, 18, other severe congenital anomalies are cared for without this kind of distress, and certainly without this kind of language being used. So this is interesting to me, and I was curious about what was driving this. I think there's some sort of mundane things that begin this sort of cascade towards this severe moral distress. One of them is this idea of gatekeeping decisions. So it's pretty common in the NICU for resuscitation decisions to be life or death decisions, for us to make this sort of no-go, no-go decision about resuscitation. It's less common for those decisions to be made around surgical interventions. And when something is a little atypical or a little less common, I think that already sets the team up to be a little bit on edge, a little bit distressed. There's some evidence for this. Children's Mercy Hospital NICU did a study over 10 years of more than 400 infant deaths, and they looked at how those infants died. In 62% of cases, care was withdrawn. In 21% of cases, care was withheld. And in 18% of cases, CPR was administered but was ultimately unsuccessful. What's interesting here is the way they defined these different terms. Withdrawal was defined as being removed from the ventilator, from CPAP, or from oxygen. Withholding treatment included withholding CPR, withholding ventilator changes despite hypoxemia, withholding therapies for hypotension, or withholding artificial feedings. I'm not saying surgical decisions weren't a part of the milieu for each baby, but this, I think, gives us some insight into how at least this team of neonatologists was thinking about end-of-life decision-making. Surgery doesn't make it onto this list of factors that they were looking at all. In fact, surgery is only mentioned one time in this paper, and that's to talk about 2 children who were excluded because they were older and had had cardiac surgery and then received ECMO in the NICU, which is where ECMO was done in that institution at the time. I think there's also some issues here with messaging and timing that can set the team up to feel on edge about decision making. In my experience, it's not uncommon for there to be a little bit of lack of coordination in surgical consults. So maybe the neonatologist who called the consult isn't the neonatologist who's on the day the consult comes. Maybe the surgeon who answered the phone call is post-call the day that the consult is actually done. And that can lead sometimes to the surgeons coming to the unit without knowledge of the full context of the case. I think there's also some kind of time and length of stay pressures that drive the team to get a consult maybe before they're a little bit before they're ready. So the neonatologist might think to themselves, it's Thursday, I don't want to wait till Friday because then ENT won't come till Monday, and so I should just get the consult today. Whereas if we had unlimited time, we might think to ourselves, should we meet as a team and go through what options we will and won't offer this family in advance? The risk of having these consults just sort of unfold as they may is that the process of consultation itself can sometimes constitute an endorsement of a surgical procedure. So parents may think to themselves, well, the team wouldn't call neurosurgery if neurosurgery wasn't a good idea. There's also this concept of the first message. So there's this notion of anchoring bias, which is it's common for us to take the first piece of information that we receive and give that additional weight in our decision-making process. And we sort of set families up for this anchoring bias when they first hear about a procedure from a surgical consultant who says, you know, the only thing I have to offer here is a tracheostomy. Not sure if that's a good idea or not, as opposed to hearing about it in the full context from the medical team. And I think when this happens, the team can kind of feel painted into a corner, that all of a sudden a decision for surgery is made without the full thought or the full process that folks might have wanted behind it. I also think this concept of saving versus creating is part of what drives the distress in this case. There's a fabulous paper written by Annie Janvier and Marc Mercurio that talk about our idea that we rescue older children who are ill, but we create newborns with disability. And what they say is when we're taking care of a 14-month-old with meningitis, we may think to ourselves, but for our actions, the child would have died. Due to his disease, he's been left with a disability. When we're taking care of a neonate who's maybe preterm, we think to ourselves, but for our actions, there would be no disabled child. And they talk a lot in the paper about how unfair this cognitive distinction might be. The next thing I want to talk about is really uncomfortable, and I've thought a lot about whether or not to even talk about it. But in ethics, when you get really uncomfortable, a lot of times that means you're sort of on the right track, and so I wanted to raise it. I also want to honor my friend Aaron Whiteman, who's brilliant and in his spare time reads old medical texts, because he's the one that sent me this reference. In 1985, Joseph Kett, who's not related to me, wrote a book called Which Babies Shall Live. And in it, he has this paragraph called A Note on Monsters. And he describes how in the 1800s, especially the early part of that century, newborns with congenital anomalies were sometimes referred to as monsters. And if newborns got this designation of monster, that meant that they weren't fully human. And if they weren't fully human, then they weren't fully entitled to human rights, like the right to inherit or even the right to life. Hopefully you're all sort of cringing and thinking how appalling that is. You're probably also thinking the 1800s were a really long time ago. But this terminology actually stuck around much longer than I think most of you would guess. And even as far as the early and mid-1980s, this kind of terminology can be found in the medical literature. So this is from the Journal of Ultrasound Medicine, Antenatal Ultrasonic Evaluation of Acardiac Monsters. So here they're talking about fetuses and children who are born, and they're using this terminology of monster. This isn't from some, far-flung corner of the earth. This is from the University of Washington. So thank goodness this terminology does disappear on PubMed, and we don't go around, one would hope, using this kind of language about babies now. But I do wonder if we've completely lost all of the emotional baggage or all of the cognitive distortions that lie behind this kind of language. A more modern example is this idea of the uncanny valley, and this is a concept in computer graphic design and robotics. And what it says is that as we see images with increasing facial realism, for a while, we find those images increasingly interesting or appealing or have an increasingly positive emotional response to them. But as they get really very similar to typical human features, as they get rendered in very high detail, but not quite perfect detail, we can actually start to engender a feeling of eeriness in observers. It's even described in the literature as creepiness. I use the words here, appeal and realism. There's all different terms used in the literature, but just to give you sort of a basic example, this is BB-8. He has essentially no human features, but he's pretty cute. An emoji has a couple of rudimentary human features. He is even more emotive. Homer Simpson, who's just so adorable, has a little bit more detail. And then the Little Mermaid is rendered fairly realistically for a cartoon, and she's able to give us even more kind of nuanced, interesting human emotion. But then as we get even more detailed, our kind of positive associations with these characters can start to take a dive. And the movie The Polar Express is actually super famous for this. So these children are supposed to be really cute, but I heard a little groaning in the audience. I think many of us find that they're actually kind of unappealing when you look at them. There's something about the way that they're rendered that doesn't look quite right. This is not just true in movies and video games, but also in robotics. This is a famous internet robot known as Creepy Robot. She's incredibly detailed, but something about her facial features appears off to many observers, and she doesn't engender usually positive associations. She makes people feel often a little bit unsettled. So this kind of dramatic, I'm pointing it at the screen in front of me so that you can all see. This kind of dramatic drop-off in our emotional response is referred to as the uncanny valley. But all is not lost. As characters become increasingly realistically rendered, they begin to become appealing again. So this is actually a CG image of Robert De Niro. It's not a photograph, but it's so realistic, it's so well done that our brains tend to interpret it as a photograph. And even if you don't find it appealing per se, you have the usual emotional response that you have to a photograph of Robert De Niro. And then here's Harry Potter, a photograph, and we're back up in kind of appealing territory. So the way I put this information together, this kind of historical concept of monsters, this current theory of uncanny valley, I wonder if we have an unconscious bias against children with craniofacial anomalies, if that is some of what drives this language of unnaturalness or nature trying to take its course in the case that we talked about. And I also wonder if this is exclusive to children with congenital craniofacial anomalies, or if this applies as well to children who have an atypical facial appearance based on a disease process, a trauma, a surgery. I think there's some unanswered questions here. If we're going to talk about our attitudes about facial appearance, I think we also need to talk about our attitudes about neurodisability. There's actually not a ton of literature about this, which surprised me, given that we so commonly counsel parents about the consequences of brain injury and about neurodisability. There's an old study that I think is still applicable and still interesting. 742 participants were interviewed in the mid-90s in Canada. 100 neonatologists, a little over 100 neonatal nurses, and then 264 adolescents were interviewed. 140 of those had been extremely low birth weight infants at birth. The rest were matched controls. And these adolescents were all part of a bigger neonatal follow-up study, long term. There were also 275 parents of the recruited adolescents. And all of these folks were interviewed about their preferences for hypothetical health states. There were 5 cases. Jamie and Chris had mild to moderate disability, 1 case of a learning disability, 1 of physical impairment. Sandy and Pat were both cases of children with very severe disability who needed help with all of their activities of daily living. And then Alex, we're not really going to talk about. That's a case of a child with mental health concerns, and we're just going to exclude that from the rest of the discussion. So what they found was, first of all, there was no significant difference in attitudes about any of those 4 medical cases between physicians and nurses. And this sort of blew the minds of the researchers. They expected to find a big difference between how doctors were looking at these cases and how nurses were looking at them. There was also no significant difference between the 2 groups of parents. So parents who had been raising now adolescents who had been born extremely low birth weight and parents of babies who had been born at term. There was not a big difference in their opinion about these cases. Where they did find differences were that healthcare providers rated all of the health states lower than parents, and healthcare providers rated the severely disabled health states significantly lower than parents. So I think this graphic provides a good illustration. On the left here is utility scores, so that's sort of how much people valued each health state. A higher score is better. This score of 0 down here, scores below this, the author's report indicate that the interviewee thinks that that state is a fate worse than death. So in the cases of Jamie and Chris, who are these children with mild to moderate disability, healthcare providers and parents actually gave pretty similar scores. For some reason, the mean isn't showing up all that well, but healthcare providers were right here, parents were right here, not a big difference between them. And we see pretty much the same phenomenon repeated for Chris. When we get down to Pat and Sandy, we see something really different. First of all, the mean score that the parents give is significantly higher than the mean score that health professionals give. And then another thing is that health professionals' mean score was below 0, meaning that on average, healthcare professionals thought that this case represented a fate worse than death. In fact, the median score the health professionals gave was also 0, meaning that 50% of the health professionals thought that this case represented a fate worse than death. We see something similar in the Sandy case. The mean of the parents' attribute is much higher than the mean of the healthcare professionals. And I'll tell you that the median score for the healthcare professionals in this case was also 0. The author summed this up by saying, when asked to rate the health-related quality of life for the hypothetical conditions of children, healthcare professionals tend to provide lower utility scores than do adolescents and their parents. And I think that gap between how parents view these cases and how health professionals view these cases is very interesting. You might think to yourself, well, that's because we know more. We have a lot more experience taking care of kids who are admitted to the hospital again and again. But remember, many of the parents in this study, half of them about, were parents who were raising now teenagers who had been born extremely low birth weight and had been coping with the consequences of extremely low birth weight for now many years. They also derived all of these cases from conditions that were noted in the children in the study when they were 8 years old. So at least many of these parents have some experience with the illnesses that we're talking about. So again, for me, this raises a question of does this difference of perspective represent a bias? The last thing I want to talk about is this concept of moral residue. I think most of you would be familiar with the concept of moral distress, which is when we know or we think we know what the ethically correct thing to do is in a certain situation, but we're constrained in some way. We're prevented from acting on that, either by hierarchy or because the parents won't consent to what we want or because of a hospital policy or other things. And this actually causes us a lot of horrible symptoms and is thought to be a big part of burnout in physicians and nurses and other health professionals. But these authors, Epstein and Hamrick, go a step further. And what they say is that we don't just have moral distress in individual cases, we also have this thing called moral residue that increases over time. So when we encounter a patient who the case is very distressing, our moral distress increases until the case resolves in some way. Either the patient dies or gets better, or the parents agree to what we were asking for, and our moral distress goes down. But it doesn't go all the way down to 0. We carry a little bit of residue from that first case with us onto the next case. And again, our moral distress builds, and again, once the case resolves, our distress diminishes. But again, it doesn't go all the way back to 0. It doesn't even go back to our previous high baseline. We've collected a little bit more moral residue. And this happens again and again over time. And they refer to this slow buildup as the moral residue crescendo. And what this says to me is that when we approach cases like the case we're talking about today, we're not just talking about the case in front of us. We've brought with us kind of all of this residue from the cases that came before. And in my mind, this can sometimes trigger an increased response to the case in front of us. I think some folks think to themselves, well, gosh, if we're not going to do what I think we should do in this case that's so extreme, when are we ever going to do it? We didn't do it in all these other cases, and now we have this extreme case before us, and we're not doing it there either. And I think that can lead to people feeling extremely distressed. So these are some of the things that I think have been driving the distress in this case, this issue of gatekeeping decisions, of messaging and timing, this concept of saving versus creating, our attitudes towards children with congenital facial anomalies, towards neurodisability, and then this concept of moral residue. So as I said before, ethics came and they reviewed the case, and they felt that it was appropriate actually for the parents to make the final decision about whether or not to go forward with surgery for this patient. So he underwent a trach and a G-tube and a VP shunt. And here he is. This is actually also kind of an old picture. He's even bigger now. He went home pretty quickly after those procedures, but came back into the hospital because of a lack of home nursing services. And he waited many, many months in the hospital for a full complement of home nursing to be established. But he's now home. He's doing very well. His parents are very happy to have him there. Like many technology-dependent children, he comes in from time to time. He's had VP shunt malfunctions. He's had tracheitis and other problems with his trach. But for the most part, he's at home with his parents, and they are enamored with him. He's also developmentally doing a little bit more than I think many people expected. He waves, he smiles, he can kind of push himself up onto his arms, and he can turn over a little bit. And so I think he's surprised many people. He's certainly not developing typically, but I think he's surprised many people with the capabilities that he's already demonstrated. I just want to thank this family for just being so gracious and allowing me to tell his story. And then Dr. Aaron Whiteman, Ben Wilfon, Doug Opel, Doug Diekema, and all the folks at Truman Cat Center. And then my partner, David Brunel's in the audience, and he's just been a huge mentor to me. And Ryan Ferdehert also at Multicare. Thank you. At this time, we can open up for questions. Doug promised me you'd only ask me easy questions, so there's that. But yeah, I'm happy to take any questions from the audience.
So thank you for an incredibly insightful talk. I think you really explained the psychology behind reactions that people have, and it's almost like a moral psychology analysis. I was curious about whether you think the neurological bias that we may have might also differ based on education and experience. So it seems to me that most of us live lives where we depend on our neurological ability, and we can't imagine our lives without it. And I wonder if in cases of brain death or cases like this, if that's part of what's going on, that families can see a range of lives that may be valuable even without that neurological capacity, whereas we can't.
I think that's a really great point. I think clinicians in particular tend to value cognition above almost all else. We think to ourselves, what am I if I don't have my brain? And that may not be true of other folks in the community who see their range of contributions to be maybe not as dependent as on cognition. There's actually a fabulous story by Annie Janvier called Pepperoni, Pizza, and Sex. And it's a short story about a baby in the NICU who has neurodisability, and the difference in reaction between how staff envisions a good quality of life for this patient and how his family does. And so I encourage everybody to Google that. It's short, and I think it makes that point just beautifully.
Thanks, Jen, for a wonderful talk, and I'm glad you brought up this issue of moral distress. These cases, like yours, are ones where reasonable people can disagree about the ultimate recommendation your team made, which was to pursue further intervention. The burdens of the treatment, the prognosis, et cetera, are all sort of uncertain, and people can come at it from different perspectives. How did you, in this case, or do you recommend supporting the kind of conversations that are needed to help people voice their disagreements in a safe way to help us sort of move forward and continue to take care of patients like this?
Thanks, Doug. I'm going to answer that in two ways. I think there's what to do about the case in front of us, and then there's also a question of what we can do about moral distress in general. I think in cases like this, an ethics consult is actually a great venue for people to talk through all of these issues. But I think ethics consultants, myself included, sometimes make a mistake when we arrive on the unit and just try to answer the ethical question, which the ethical question asked in this case was, do we have to offer all this stuff to the family? And ethics came and answered that question, but I think we neglected to really reflect on what was behind all that question and to really unpack why people were feeling so distressed. And I think when we fail to do that, the distress is ongoing, and I think that leads to this perception that like ethics comes and they don't do anything and nobody feels better and it's just the same, which probably doesn't happen here. So I think we need to kind of correctly diagnose what's going on in the unit and address both this formal ethics philosophy issue and also what's going on with staff. As far as treating moral distress, there's a lot of literature lately about moral distress. As far as I can tell, nobody has solved this problem, and if I had a solution, I would sell it to all the hospitals and make $1 million. But I think there are a couple things we can do to mitigate it. First, the first time I ever talked about self-care in medicine was during my palliative medicine fellowship, which was like my 10th year of training. And self-care is actually a concept that we should be teaching to our trainees much before that, and not only if they're dealing in palliative medicine. And so when we come to a situation that's going to cause moral distress and we are exhausted, eating poorly, drinking too much, not exercising, not having any sort of spiritual practice or fulfilling practice outside of work, we are much more susceptible to be sort of brought down by moral distress. When we have those other things in place, when we're taking care of ourselves well, I think we're a little bit more resilient. I think also for our own selves, knowing oneself and when you're experiencing moral distress is extremely important. So for myself, I know when it's like Margarita Tuesday at my house, that's because I'm having moral distress. And so I've sort of become aware of how I know when I'm distressed, and so that I can intervene. But I think it takes a little bit of time to sort of know yourself and realize that that's what's happening. I also think unit managers and physician team leaders and other folks need to be a little more tuned into this as an issue with staff members so that they can address it. One of the best ways to address it is talking about it, although forcing people to talk about it is not helpful. And so those kinds of interventions, I think, are really important, and hopefully the literature continues to evolve in how to really treat this as the huge problem that it is.
Thank you for a very compelling talk. The cost of caring for a child who has these kind of disabilities long-term, short-term and long-term, are going to be substantial. Is financial discussion of that nature part of an ethics discussion? If we offer the parents an opportunity to save this child, if you will, do we not also have a responsibility as a society to help the parents along that journey? It's going to, no parent can afford to do this, so do we not have a responsibility to assist them in some way?
I'm so glad you asked that question. I have two answers. One is, absolutely we have a responsibility to help families who are raising children with special needs. And both children with severe special needs and children with mild to moderate special needs, those families need much more help than we're giving them. They essentially enter a full-time 24/7 job that we would never, the union would never let us employ a nurse in the way that we employ these parents. And it's just unfair, and it's hard to see them kind of try to cope with that. And as a society, I think we owe them more than that. I'm also going to use your question to talk a little bit about this idea of futility and rationing, because this is a concept that comes up a lot when we're talking about cases like this. You often hear folks say, what about the cost? Interestingly, we don't tend to say that when we're doing something we're all excited about. So if it's like, we're going to separate the first set of conjoined twins in this special way, and it's like super exciting, and we're going to be on the news, we don't tend to talk a lot about how much that costs. I think it's really important to distinguish between questions of futility, which is whether or not something will work for a patient, and questions of rationing, which is whether or not something is worth doing financially and otherwise, resources. When we're talking about rationing, there's really two types of rationing: implicit and explicit rationing. Explicit rationing is where a country, a health system, an insurance company gets together and says, we're going to treat these conditions, but not these conditions. We are going to prioritize treating people with this, but not this. If an influenza outbreak happens, here's how we'll distribute ventilators. And in theory, these determinations are available for the public to see. They're transparent. Maybe the public hopefully was able to comment on how folks are ranking these different things. And they're also applied systematically. So if you're the president of the hospital, or if you are homeless, these policies are applied to you in the same way. You don't get a ventilator just because of who you are. They're all applied systematically. That is considered not only okay, but a good thing, and a thing we should be doing much more of. it raises concern in the public about this idea of like death panels and stuff. So it's a scary thing for America, but it's something we actually must start doing, or we've already run out of money. Implicit rationing is different. Implicit rationing is when we sit at the bedside of one particular patient and say, is this financially worth doing? And we make a decision to go forward or not go forward with treatment for that patient on that basis. That is not applied systematically, opens us way up to issues of bias. We're going to make a way different risk-benefit calculation at the bedside of a malpractice attorney than we are of a person who's here undocumented and has no family at the bedside. And implicit rationing, these sort of bedside decisions about finances, are generally not considered to be okay in medical ethics. We really need to push ourselves to do more explicit rationing so that we can avoid doing implicit rationing at the bedside.
Thanks again for your talk today. You posed a question during the talk, which I thought was interesting, which is whether we have an unconscious bias towards patients with craniofacial abnormalities. And I was just sort of thinking through that after you posed the question. And I was wondering whether you think it has anything to do with how we localize our sense of identity or self, and how much that requires perhaps some internal reflection about what it is what actually constitutes self, and where we may have some biases in terms of where we even place that within the human body.
Yeah, I think that is such a great point, and I feel like you might have studied philosophy in college or something. Yeah, I mean, I think these questions of severe craniofacial anomalies or severe neurodisability push us to really think about how we are defining what it means to be human, what it means to have a good life. And I think we don't like to think of ourselves as being faced with those questions about sick children, but I think some part of our brain is reflecting on that. And the more that we can bring that up to the surface and talk about it, I think the more we'll be able to treat children similarly. Hello, Craig Jackson.
Hi, Jen. And as you know, I called you a couple of months ago about a patient we have that's very similar to this here in our hospital right now. So we're struggling with this a lot. One of the things that causes our nurses, our surgeons, and others to struggle is that they weren't a part of the original conversation about comfort care. So in this particular instance, should we continue the pregnancy or not? Should we, it's a resuscitation comfort care. So could you give us some advice about not only how to do comfort care counseling better, but also how to communicate the content of that discussion so that others can say, yeah, they really did try. It wasn't just they just had a 2-second conversation and let's do everything kind of a thing.
Thanks, Craig. That's a really good question. First of all, I think when we're having these discussions, as physicians, we need to make a better attempt to include other team members. And it's sometimes easy for us to leave out the nurses because we make the care conference on our own schedule. And it's really easy for us to leave out respiratory therapists because they're covering so many patients and maybe they're different each day on the unit. And I think making a better effort to include all the specialties is helpful. But my biggest advice is really that I think that's one of the things that can be so helpful about a palliative medicine consult. It's at least a signal to everybody who goes in the chart that some of these big issues about life and death, about quality of life, about what's worth doing, about what the parents' goals of care are, it's a signal that these questions are being addressed in some form. And you folks here have the luxury of a really fabulous, robust palliative care team. Our team at Mary Bridge is smaller but mighty. But I think sometimes one of our roles is to hold that sort of institutional knowledge that we had a care conference last week. Here's what was discussed. And I can say that to a staff member on Monday. And then on Tuesday, I can say that to a different staff member. And then on Thursday, when people have forgotten about that again, I can say that again. And I consider that to be one of my important roles on the team. And so I would encourage that in cases that are complex, difficult, uncomfortable, a palliative medicine consult, even if they don't change the decision-making trajectory, can just be this important marker that those decisions are being thought about and addressed. Hi, Aaron.
Great talk. You said it was the least interesting part of the case you presented, but I wonder if you
That's
could
correct, thank you.
spend a little bit of time just a moment commenting on how you would apply something like a best interest standard, or a best interest standard specifically, to a newborn with profound disabilities and expected severe cognitive disabilities.
I came prepared for this question. I really didn't plan him in the audience, even though he's one of my closest friends. I was actually kind of worried what he was going to ask me. So the best interest standard is sort of the most famous standard for pediatric decision making. We use other standards as well. The harm principle is one of the other most famous standards that originated from Doug Diekema out of this institution. But under the best interest standard, a surrogate decision maker has to determine the highest probable net benefit among the available options. This is really a risk-benefit calculation, a benefit and burden analysis. And the things we weigh in the benefits might be things like survival, the ability to form family relationships, this concept of an open future, that a child will be able to sort of experience life. And the things that we might put in the burdens category in a case like this are life with a developmental disability, repeated hospitalizations, pain and suffering. The problem with the best interest standard that at the moment no one has solved is that these things are really hard to weigh against each other. And reasonable people weigh them differently. We've all heard or taken care of adults who had actually a pretty good chance of survival from their cancer but decided not to go forward with chemotherapy. Steve Jobs is an example. We've also heard about adult patients who had the ability to decide for themselves, who wanted to go to the ends of the earth to try every single experimental therapy, even though it had a very low likelihood of helping them. And those adults chose, essentially, survival over quality of life. And in this country, we let people make those different kinds of decisions, and we also let parents make those kinds of decisions for their children when it really comes down to a question of values. So this is stolen a little bit from Mark Mercurio, who's so smart. Basically, a way to think about pediatric decision making is there's a lot of times where the decision, the treatment is clearly not beneficial. Like there would be no benefit to amputating this patient's legs. That's obvious. Treatment should not be offered. There's times when a treatment is clearly beneficial. So if a otherwise healthy child comes in, choking, we're going to resuscitate them. And there's no kind of argument about that. And if the parents tried to decline that kind of therapy, we would actually go to court, get an emergency court order to be able to provide it. But then there's all these times in the middle where it's not clear if the treatment's clearly beneficial or clearly not beneficial, where that decision, the balance of the benefits and burdens, really hinges on a question of values. And in those circumstances, we tend to think that parents are in the best position to make a values-based decision for their children. That this is referred to in neonatology as the gray zone, but I think it's a useful concept outside of neonatology as well. And in this gray zone, where the burdens of therapy might be high, the benefits might be uncertain, and it's really a question of values, we tend to let parents decide. And so that's how I think about this case, and I think this case falls into this gray zone. I will also tell you, 90% of pediatric ethics is deciding, where on this spectrum you are. Are we going to go to court and compel this treatment? Is this a treatment that's so non-beneficial we don't even need to offer it? Or is this a treatment where the parents should decide? These are hard determinations to make, and with experience and reference to the literature, we all get better and better at it over time.
So along those lines, so it seems like we often present to the patient and the family from a consequentialist or utility perspective, whereas the families often seem to come from an entirely different framework. Like this family seemed to come from more deontological, even teleological.
Yeah.
And so there's an incommensurate ethical framework. And I wonder to what extent that causes moral distress.
Your audience is full of philosophers. So great. I think you're hitting it right on the nose. I think healthcare providers tend to think about these cases in a different way from families. But I also think good ethics consultants are not just using one framework to help make their decision. They're thinking through this in terms of principles. They're thinking through this in terms of casuistry, in terms of feminist ethics, in terms of the ethic of care. And they're able to sort of toggle between all of those and help triangulate to hopefully the right decision. But I think your point is well taken, and it's great. And we also, I think, in medicine tend to look for answers a black and white, yes, no, go, no go, are we a DNR, are we not, when many of these cases are just so many shades of gray. Any other questions? Well, before we finish, I do want to put up Ben Wilfon turned me onto this really beautiful poem that I think highlights, as you were saying, some of the differences in the way that maybe health professionals think about things, and kind of what's important to other folks. You can just read it to yourselves. Well, I just want to thank you all for your kind attention and your lovely questions, and I appreciate the opportunity to be here.